Hello, I'm Alan Weil, Editor-in-Chief of Health Affairs. I'm pleased to announce the release of our October 2022 issue, which occurred about 30 seconds ago. The October issue is devoted entirely to the relationship between disability and health. There's the cover for those of you who still like to see things on paper. About 1 in 4 US adults and 2 in 5 adults ages 65 and older have a disability. And as the US population ages and rates of chronic conditions rise throughout the population, rates of disability will continue to increase. Now, as you'll hear throughout today's discussion, the term disability covers a very broad range of conditions affecting people across the population. While rates of disability are not uniform across different groups, the presence of disabling conditions spans ages, geography, race and ethnicity, educational attainment, income, and more. And notably, disability is not synonymous with poor health. The link between disability and health is complex. It reflects social constructs and phenomena such as discrimination, the structure of employment, barriers to accessing healthcare, and more. And these are the various themes that you'll be hearing about more today. Today's theme issue on disability and health fits within the broader equity agenda that we've embraced at Health Affairs, which leads me to the important topic of intersectionality, the fact that ableism is one form of discrimination that operates in conjunction with other forms of discrimination related to race and ethnicity, sex, gender identity, and more. In that vein, I need to acknowledge that the composition of the presenters in today's event does not reflect the racial and ethnic diversity of our country as a whole or of people with disabilities. As with all of our theme issue release events, our speakers are the authors of the papers in the issue, and the authors in health affairs, drawn largely from academic institutions, are not as diverse as the population at large. We have a comprehensive equity agenda at Health Affairs working hard to change this fact, but we're in the early stages. We have a long way to go. The composition of our authors is, as you see it today, not the fully inclusive one we aspire for it to be. One more note about the issue: language is important. Language surrounding disability is in flux and preferences are varied. We've deferred to author preferences regarding language surrounding disability. Particularly, some use person-first language, such as person with a developmental disability. Others use identity-first language, such as deaf patients. You'll hear both of these during today's event and in the issue, and it reflects the preference of the speakers. Now, I'm so excited by the release of this issue. I was introduced to topics surrounding disability in my days running the Medicaid agency in Colorado almost 3 decades ago. Medicaid is a critical part of the service opportunities and the opportunities for a dignified life for people with many different needs. We'll come back to the role of Medicaid, but this issue touches me personally. It's been an interest of mine personally for a long time, and it's really wonderful to be at a place where we have the content that we can share with you today. Today's event will lead off with remarks from Dr. Rich Besser, President and CEO of the Robert Wood Johnson Foundation, followed by the reading of an original poem that appeared in the Narrative Matters section of the October issue. We'll then move to 4 panels, the first including our 2 overview paper authors, the second looking at care delivery topics. We'll take a short break and move into topics including data and evidence, as well as some of the intersectionality topics that I mentioned before. We try to set up to take audience questions. We're having a little technical difficulty with that. If we can fix it before the sessions begin, I'll encourage you to ask questions and I'll explain how that works in a moment. We have a lot of other activities planned around this issue. We've produced an interview, a film with an interview with disability rights activist Judy Heumann. We have a community event in Rockville, Maryland, Thursday evening. You can find all of these described on our website. I do want to thank our theme issue funders, the Ford Foundation, the Robert Wood Johnson Foundation, the John D. and Catherine T. MacArthur Foundation. They've supported the issue, and their funding makes it possible for us to make all of the articles in the issue available at no charge to our readers. And you'll hear more from our theme advisors, Drs. Lisa Iazzoni and Javier Robles. A special thanks to them as well, and to our assigned editor, Ellen Bayer, who shepherded the issue through our processes. It's now my pleasure to introduce to you Dr. Richard Besser, President and CEO of the Robert Wood Johnson Foundation, a position he has held since April of 2017. He's the former acting director of the Centers for Disease Control and Prevention. He led the CDC's response to the H1N1 influenza pandemic. He was ABC News's chief health and medical editor, where he provided medical analysis and reports for all ABC News programs and platforms. He's a leading voice on the topic of equity and advocating for full inclusion of people from all backgrounds and people with disabilities in particular. We're pleased so much to have the support of the foundation and pleased to have you in person to join us to kick off the event. Dr. Besser.
Thanks so much, Alan. It is truly an honor to join you today for this important symposium in conjunction with the release of the special issue of Health Affairs on disability and health. We are so pleased that this issue has come to fruition. At RWJF, we're focused on advancing health equity, and yet all too often, conversations about health equity completely ignore the impact on people with disabilities. The pandemic really shed a light on the health inequities that people with disabilities have always faced, from challenges in getting access to important services and care, to the ways in which important discussions about these issues did not include the people most impacted by them. At RWJF, our focus is on working with others to build what we call a culture of health that provides everyone in America a fair and just opportunity for health and well-being. Simply put, health equity is not possible without the genuine inclusion of people with disabilities. We've missed opportunities to be more inclusive in the past, and because of that, we're striving to do better. We stand firm in our commitment to make disability inclusion part of our culture and of our work. This means being more intentional about centering disability and racial equity and the ways they intersect in our grant making. It also means continuing to enhance our website, our facilities, our HR policies, and our operations with disability inclusion in mind. It's a journey and we are far from done, but we are making important progress. We believe that finding solutions begins with ensuring the places where we live, learn, work, and play do a better job of meeting the needs of people with disabilities. This includes working to advance laws, regulations, policies, and practices that expand disability rights, accessibility, and inclusion. And for those of us in philanthropy, it means engaging with the people and communities who are most impacted by our work in ways that will lead all of us toward much needed change. I do want to amplify an important point that shouldn't be lost throughout the conversation today. As Alan mentioned, it's critically important that as we celebrate the publication of new and important research, we also examine how our current systems for academic publishing tend to disadvantage researchers of color, including researchers of color with disabilities. I encourage Health Affairs to continue examining how you can leverage your role and influence to advance the work of disabled researchers of color beyond this event. The scholarship and research in this month's Health Affairs and the conversations that will take place today are a great start. Let's just make sure we keep pushing for more. Thank you to all of the authors who've contributed to this special issue, to the speakers who will be part of the many discussions throughout the afternoon ahead, and to those of you who've joined today's discussion. I'm excited about this special issue and the symposium, and I'm truly hopeful about the changes it can lead to. Thank you so much. And Alan, I'll toss it back to you.
Thank you, Rich, for those words. And I am told we now have fixed the problem with the Q&A. Apparently, the only challenge is that people are going to have to refresh their browser page in order for the Q&A box to show up below. So I'm going to just stall for a moment and explain that if you're in the live audience, you'll be able to ask a question if you in the Q&A section right below the screen where you're watching the video. I will do my best and other moderators will do their best to get to your questions. It's best if they are short and of general interest. Get them to us a little bit ahead of time so that we can read them as we're also running the agenda. But I do understand that you'll have to refresh the page and it shouldn't interrupt your ability to watch the programming. You can do that at any time. It's now my great pleasure to welcome Colin Killick, the Executive Director at the Disability Policy Consortium. Colin will read their original poem, Saving Medicaid and Ourselves.
Thank you so much. Thank you, Alan. Thank you, everyone, for being part of this remarkable event. Folks can see me all right? So since I've been involved in disability rights work for the last decade, first as a volunteer, then as an organizer, and then a graduate student, and for the last 4 years as executive director of Disability Policy Consortium, which is a disability civil rights advocacy and research organization based in Boston. And over about that same time period, as a way of finding community and of dealing with my feelings of being a disabled person in this country and of keeping going, frankly, I have been writing and performing poetry. And so, well, ordinarily at an event like this, I would be on a panel probably with one of these phenomenal people with whom I have done policy work with. It is an incredible honor to be able to bring these two facets of my life together and perform for you folks. So this is a piece that was written about the 2017 Medicaid protests, when people with disabilities went to the Capitol and literally put their bodies on the line to defeat efforts that would have gutted, in my view, Medicaid and tremendously harmed people with disabilities. So this piece is reflecting on those experiences. It's called Saving Medicaid and Ourselves. When it was all over, I thought back to the dance floor. We had spent the day marching and chanting, camped outside the Senate in a pile of wheelchairs and tarps, checking Twitter for our prognosis. Likely fatal. But our phones aren't out now. We're all cleaned up. The band is playing and the fake wood is full of wheelchairs and walkers and people with white canes, and we are goddamn pretty. And we are with our people. And there is no one here to stare at us, to roll us flat into motivational posters. And we are dancing like there is no tomorrow, so they can't kill us at dawn. And isn't it funny, the way we refute our own fragility? How all this is against medical advice. How we are objects with warning labels and we shrug them off with each step. How the police weren't worried when they dragged my friends from their wheelchairs. So why stop dancing now? As for me, though, I've always hated dancing. Partly it's the crush of bodies, the panic that rises in my spine with every knock and jostle on the crowded floor, and partly it's the way I think I look. My brain has never spoken a language that my body understands. Tying shoes and writing words eluded me. Teachers clucked their tongues, issued zeros, told me to try harder. In first grade, I failed, Simon Says. No matter how loudly they explained, I could not make my body mimic theirs. So the idea of doing this for fun, being pleased to be marked against a rhythm, wanting to be seen in motion, made no sense. Until that night, when no one had to ask to be looked out for, and all of us had bodies we were still struggling to love, and I stopped noticing the beat, or my feet pointing in the wrong direction, or that I had a body at all. I was just a cell, for the first time part of something large, unbroken, and just discovering what it could do. It was almost midnight, and the band struck up another classic. We rose whatever appendages we could, flung out our own defiant rhythm, and screamed into the air, I will survive! I will survive! At 4 a.m., I woke slowly with no alarm, like a voice had gently whispered in my ear. I checked my phone and somehow we had won. A mind changed just when we needed it, and for now, we were safe. Do not know if this is a dream or a new universe just born. Only that we made it, that it is ours. Thank you all so much.
Thank you so much. And that poem was selected in a highly competitive process we went through for it. Really appreciate you sharing that with us today. We'll now move to one of those panels you referenced as you got started. We're going to kick off with a panel that includes two of our overview paper authors, and we're going to discuss sort of the overview of where we are and where we find ourselves. The first panel includes Lisa Iazzoni, Professor of Medicine at Harvard Medical School and the Mass General Hospital, and Javier Robles, Professor of Kinesiology and Health and co-chair of the Rutgers University Disability Studies Committee at Rutgers. Lisa and Javier were our theme advisors, and we appreciate all of the extra effort they put in to make this issue possible. The panel also includes Linda Long-Balio, Assistant Professor at the E.K. Schreiber Center in the Department of Family Medicine Community Health at UMass Chan Medical School, and Dr. Anjali Forber-Pratt, the Director of the National Institute on Disability, Independent Living and Rehabilitation Research within the Administration for Community Living, part of the United States Department of Health and Human Services. Welcome to the four of you, and looking forward to setting the stage here for the conversation. We're going to start because we have authors of two of our overview papers who really describe where we find ourselves with respect to issues of disability and health with those two presentations. So, Dr. Iazzoni, I'll turn first to you to present your paper.
All right, I am talking about laws and whether the laws have resulted in equitable care for people with disabilities. The laws go back almost 50 years. Section 504 of the 1973 Rehabilitation Act, which refers to programs receiving federal funds. The 1990s Americans with Disabilities Act that extended protections to other public and private settings, and its 2008 Amendments Act. And then finally, Section 1557 of the 2010 Affordable Care Act, which provides additional protections against disability discrimination in healthcare services. Okay, next slide. The short answer to the question of our title about equitable care is largely no. Okay, next slide. In the overview article, we had the space to give 6 examples of why this is largely no. And so the first one has to do with disability data. The Affordable Care Act, Section 4302, required the Department of Health and Human Services to develop data collection standards for disability, as well as some other things like race, ethnicity, sex, primary language, for federal data collection and reporting. It chose the 6 questions from the American Community Survey. And although these questions are now used in federal surveys, disability data are not collected in administrative health records or public health surveillance systems. With no disability data, there's no disability information for decision makers, which was especially a problem during COVID-19 pandemic. Next slide. All right, Section 504 and the Americans with Disabilities Act require effective communication between healthcare providers and patients with disabilities that affect oral or written communication. Many approaches and technologies now exist to accommodate communication needs. However, ineffective communication remains one of the most common causes of ADA lawsuits. I was privileged to lead with wonderful colleagues a 2019 to 2020 survey of outpatient physicians nationwide, and 71% reported not knowing the correct way to determine accommodations. By the way, the correct way is to ask patients and then try to meet their preferences. Next slide. Okay, physical access to care. Medical diagnostic equipment is frequently inaccessible for people with disabilities, especially mobility disability. This inaccessible equipment leads to inadequate care and delayed diagnoses. The ACA Section 4203 required federal government to specify accessibility standards for major types of medical diagnostic equipment, such as exam tables, weight scales, and imaging equipment. And the rules were finalized at the end of the Obama administration in January 2017. However, for reasons I don't have time to go into, there are no federal mandates yet to require healthcare providers to have accessible equipment. Next slide. All right, with some exceptions, most healthcare professionals do not receive training about caring for patients with disabilities. Discriminatory and ableist attitudes persist among healthcare providers. 82% of physician participants in an outpatient survey believe that people with significant disability have worse quality of life than other people. This is largely an erroneous assumption that leads to worse quality of care. There are cross-disciplinary groups along with consumers that are specifying disability competency training standards, but they remain to be widely implemented. Next slide. Okay, perhaps I think the seminal ADA ruling was the U.S. Supreme Court Olmstead ruling in 1999, which found that under the Americans with Disabilities Act, people with disabilities have the right to live in the community rather than be institutionalized. This is to assure, quote, equality of opportunity, full participation, and independent living. In Olmstead, the context was Medicaid, states funding home and community-based services, or HCBS. States vary widely in Medicaid expenditures on HCBS, and recent studies have found that there's about 820,000 people on Medicaid HCBS waiting lists nationwide. Thus, many people with disability lack the supports for the independent living conceived under Olmstead. 5 or 6. Next slide. All right, 6. Under the ACA safe harbor exceptions, there were some allowances for some health insurers to exclude or restrict coverage for people with pre-existing conditions, including disabilities. The Obama administration developed regulations under ACA Section 1557 to prevent discrimination by private health insurers against people with disabilities, but the Trump administration narrowed the scope of Section 1557. Therefore, the Biden administration has worked to reverse these changes, but the final resolution remains a work in progress. Okay, next slide. So in our conclusions, we kind of pulled a Hail Mary here to see what we could do to motivate changes, since it's been almost 50 years of laws and still we do not have equitable care. And so, as I've suggested, much remains to be done to achieve equitable care, and to motivate this, we propose that the U.S. should consider joining the 185 nations around the world by ratifying the 2006 United Nations Convention on the Rights of Persons with Disabilities. Next slide. Thank you. Thanks. That's the end.
I now want to turn to Linda Longbalil to present the second of the overview papers. Over to you.
Thank you. Thank you for this opportunity to present our paper today. And thank you to our lead author, Monica Mitra, and my fellow co-authors, Ian Mara, Angel Miles, and Steve Kay, for working with us to advance health equity and reduce health disparities for people with disabilities in the United States. Next slide, please. Defining disability is always a challenge. There are actually 67 definitions of disability in federal law. But broadly, historically, disability has been defined using the medical model, which assumes that disability resides within the body or mind of the person. In the 1970s, activists began to talk about the disabling environment, arguing that it was the disabling and inaccessible environment that was disabling. Over time, many of us have come to use an interactive model, which integrates elements from both the medical model and the social model. It is in this overlap between the medical model and the social model, between the person and the environment, where healthcare and health policy happen, and both need to be addressed to ensure most positive outcomes. Next slide, please. Just as there are multiple definitions of disability, so there are multiple estimates of the prevalence of disability. Estimates vary depending upon the survey questions asked and the survey method used. But the bottom line is that there are more people with disabilities in the US population than you might think. Next slide, please. Gloria Cron and her colleagues wrote an excellent article about the cascade of disparities that result in poor outcomes for people with disabilities. There are disparities in equitable access to health care, as Dr. Izoni and later Dr. Lagu have outlined in their papers. There are disparities in preventive care, People with disabilities have difficulty getting mammograms and pap smears. There are disparities in health promotion practices. Just try and go into the gym if you have a disability. There are disparities in attention to care needs. Everyday care for people with disabilities is underfunded, and direct care workers are undertrained, underpaid, and undervalued. All of these factors pile on top of the adverse health conditions and behavioral health conditions, including secondary conditions, that people with disabilities experience, to create enormous gaps in the care that people with disabilities receive. Next slide, please. It's important to remember that these disparities are compounded for people from additionally marginalized groups, people of color, women, and members of the LGBT community. And it is important to view policy through a disability justice lens, which prioritizes the needs of these historically excluded groups. Next slide, please. There has been some progress made. The Affordable Care Act, as Dr. Iazzoni noted, didn't completely address the issue of pre-existing condition exclusions, but it did improve things in that way. It also created premium subsidies and expanded Medicaid so that more people in general, including people with disabilities, would have access. It also created Medicaid buy-in programs, although those are not the Medicaid buy-in, that's not the Medicaid buy-in program that I'm referring to here. The Medicaid buy-in program that I'm referring to here is a program that was created by the Budget Balanced Act of 1997 and then expanded in the Ticket to Work Act in 1999, which creates a Medicaid buy-in program that states can adopt to allow working disabled people to buy into Medicaid, to purchase Medicaid through premiums. And it's a good program, but unfortunately, many of the states that implement this program still impose fairly stringent income and asset limits. There are a couple of states that do not impose these limits, and they've had a good experience. And the federal government really should enhance federal funding, the federal match, to encourage other states to eliminate the income and asset limits as well. Next slide, please. You heard Dr. Iazzoni refer to the Olmstead decision, and which was based on the integration mandate of the Americans with Disabilities Act. The Olmstead decision required states to rebalance institutional and community services, to take an even-handed approach to them. And it's been found that if you do this gradually, if you rebalance institutional and community services gradually, you can do so in a manner that saves money. There's an excellent article by Stephen Kay on this topic. Additional improvements that could be made would be a Medicare HCBS benefit, home and community-based services benefit. Unfortunately, a lot of older people think that Medicare is going to provide them this service as they age, and in fact, that is not the case. So a Medicare HCBS benefit would be a vast improvement. And of course, the ideal option would be a universal public long-term services and supports option. Next slide, please. It would also be important to expand the scope of services covered by public and private insurance. Limits in the scope of services such as medical necessity and the Medicare homebound requirement limit access to care in ways that fly in the face of the ADA's integration mandate. One option for improving medical necessity definitions is done in the state of Delaware. And the Medicare homebound requirement should just be eliminated. Interestingly, it's not required for hospice care. And it's interesting that we require people who need services to only receive those that they need in the home when they are expected to live a long life. But for those whose time on earth is limited, we do not require, we do not impose such a requirement. So very interesting irony there. One way for states to manage costs, if they're concerned about those, instead of using restrictive definitions of medical necessity and without the Medicare homebound requirement, is to utilize integrated care programs, which are being used in many states. They're being experimented with some success. That would be another more thoughtful approach to addressing these concerns. Next slide, please. And lastly, it is important to foster research to inform policy on reducing disparities by designating people with disabilities as a health disparity population under the Minority Health and Health Disparities Research and Education Act of 2000. This would require disability identifiers in survey and administrative data, and it would help to identify people with need for long-term services and supports. Lastly, it would authorize funding for research and demonstration projects for training and educating health professionals to reduce the disparities in healthcare outcomes. That's the next slide, please. Thank you. I appreciate the opportunity to talk with you today, and I look forward to the discussion.
Thank you so much. I want to bring our two other panelists in. I'll start, Javier, with you. You were one of our theme advisors. There's a lot of content here. We're going to get into a few more detailed questions, but I wonder if you had some opening thoughts about the content that you were able to engage with in this issue.
Obviously, some amazing research and articles by our two authors. One thing that strikes me is that they put out solutions to a lot of these problems, and these solutions have been something that have been ongoing, but yet policymakers to date, refuse to do something about this, even after what we saw with the COVID-19 pandemic and how people with disabilities were disproportionately affected, especially individuals who lived on the margins or are marginalized, individuals of color were affected as well. So it's difficult. I mean, as a person with a disability myself and an educator to deal with the contradictions of everyday life of how we have these solutions out there, yet they're not, taken seriously or, taken up to do something about them.
Well, that's a perfect opportunity to turn to Dr. Anjali Forber-Pratt within the Department of Health and Human Services. You've heard already a number of references to policy, and be interested in your reactions to these overview papers.
Yeah, absolutely. And thank you so much for the invitation to be here today. And I am sitting in a manual wheelchair and have brown skin and black hair and wearing a red and blue plaid shirt. I think that one of the really important pieces that everyone has already touched on is the fact that it takes us all. Like it takes researchers, it takes people like myself who are squarely within government. It takes folks who are advocates from the disability community. It takes editors and reviewers for academic work as well to really push a lot of these issues that we're talking about. And going back to something that was also described too, we have to really analyze all of these issues from a systemic lens and ask ourselves, why is it that we don't have multiply marginalized, disabled investigators who are conducting this work? Why don't we have policies that are cross-cutting and so forth that includes the vast needs of the 67 million Americans with disabilities, and what are those unique needs of those who are multiply marginalized? And I can't say this often enough that it takes an entire village. It takes folks from all of those different perspectives to really be able to move the needle in a coordinated way.
I appreciate that comment, and it makes me wonder about something that I'd like to put out as the first question to all of you. As you note, the number of people with disabilities is quite large, but the types of disabilities among those 60 plus million people are quite variable. And when we talk about disability policy or programs for people with disabilities or inclusion of people with disabilities, I feel like often policymakers have sort of a mental model of a person in a wheelchair or an autistic child or something, but not capturing the breadth of the experiences that we're trying to discuss. And so I wonder, how do we make sure that disability policy is sufficiently robust and comprehensive to get beyond some of these subcategories or generalities or generalizations people might make about what it means to be a person with a disability? Who'd like to talk about the heterogeneity within the population?
I think I would like to talk about it a little bit because we saw something like that during the pandemic here in New Jersey when we started a group called the New Jersey Disability Action Committee, and we did some research on legislation, and most of the legislation really catered towards a particular group of individuals with disabilities, which was intellectual and developmental disabilities in particular. But when we looked at that legislation closer, it was legislation that could have benefited a whole group of people with different disabilities. So, when you're talking about how, lawmakers think and people who develop policy think, they have this idea of what disability means, as opposed to what the reality for a lot of us is, that it means spinal cord, it means individuals who are blind or deaf or hard of hearing. And it's a broader category. So, I think it's important for us to find a way to basically educate them about what a disability means. So, the poorest of the poor and the most marginalized aren't affected by, the way that they think and have thought for many, many years.
Lisa, yes.
I have two comments on this. And the first has to do with data. And we'll be getting to this in panel 3. So panel 3 authors, I apologize in advance for anticipating what you're about to say, but you can't ask a single question about disability because the phrase people with disabilities, as you said, Alan, is almost meaningless. It's such a diverse category. But this also makes it difficult to convince policymakers to collect data on disability because you don't just need one question, you need a whole range of questions. And it's important to note that there are some people who might have multiple disabilities. And so people might check one box, but also check another box. And so I think, again, panel 3 will be discussing this, but that's one of the issues is that we don't have disability data at all, but we need more diversity when we collect the information. And then the second point that I want to make is that there's a concept called universal design, which is very kind of thought about in the disability community. And that is that whenever humans design anything for any purpose, when they design a building, when they design a policy, when they design a procedure, they should just systematically think through who are all the people who are going to be using this and how can we make it as universally accessible as possible. And universal design is not an absolute, as we can tell for the example of bathrooms. It's hard to design a bathroom that every single person will feel entirely comfortable in. But we can at least get to a point where the majority of people will be able to use a system. And again, this requires a systematic going through what are the functional abilities, what are the kind of cognitive, what are the whole range of skills and abilities that need to be at play for somebody to get access to a particular issue.
Linda, yes.
And just to build upon that, I think programs that are accessible to people universally rather than categorically are very much can very well address the needs of people with disabilities much more effectively than these little carve-outs that our system is full of. If we just provided universal health coverage and universal LTSS coverage, that would go a long way for addressing the needs of all folks with disabilities and everyone else.
And Anjali.
And I would also say we also need better education even within our own disabled community. So by that, I mean, oftentimes disability has been reinforced by society as being viewed as something to avoid or something to be shameful of. And so there's many individuals, even within the disability community, who don't think of their disability or condition or disease as a disability. So for example, an individual with Crohn's disease or ADHD or long COVID, there's many individuals who may latch on to the specific diagnosis that they have been given, but who don't realize that they are a part of that 67 million. And so some of that comes from within our own community of education, but also those of us who are using the term disability as a form of identity and as something that can be celebrated and a marker of pride and so forth, that it's not something that we must be ashamed of or to try to hide from.
These are all really helpful. I appreciate it. I mentioned in my opening that my introduction to disability policy came as I was responsible for the Medicaid agency in Colorado. And we are, of course, a policy journal. So we talk a lot about sort of attitudes in education, but at the end of the day, we're focused on what can be done. Lisa, in your overview, and Javier, in your response, you mentioned, we have policies, but that doesn't necessarily get us there. So I have a close affinity to Medicaid because of my longstanding work with it and view it as an essential source of support for people with a broad range of disabilities. But I'm also aware of the limitations of using a program like Medicaid to try to address those needs. I wonder if any of you want to comment on opportunities for improving and addressing some of the inequities that were described within the context of Medicaid, or places where you see particular success that you think could be emulated. After all, it's run state by state. I just would love to get a focus on the Medicaid angle here. Lisa, I see you.
Yeah, I'll take that. I think that Medicaid does really well in some things, and much better than Medicare does. For example, getting assistive technology is typically easier, and I'm generalizing here. There are going to be people who are going to disagree with me on that, but in general, compared to Medicare policies, Medicaid is a lot better. However, we've already talked about this, Ellen, that Medicaid is a joint federal and state program. States differ widely. And it just depends on where you live. I mean, with another project that I've recently completed, people who need long-term services and support sometimes shop the state because they realize that some states are better than others. Now, that's a risky thing to do, to move to a place where you think that home and community services are going to be more available, because you still have to establish eligibility for Medicaid in the new state that you move to. But we see just dramatic variations across states in terms of their generosity towards people with disabilities, especially the home and community-based services. And so I think that the whole notion of universal design doesn't apply to Medicaid, because it's 50 plus different programs.
Other thoughts on this topic?
Yeah, I'll jump in. And
Please.
I think that home and community-based services, are exactly as Lisa was just saying, there's such variability from state to state. From a researcher lens, though, I would say that that there's a ripe opportunity to really be able to assess these issues at the state level and to do state by state comparisons, that some of which was highlighted in this issue and by many researchers. Because if we focus too much only at that individual level, we miss what's happening with that variation state to state, and then truly what's actually happening nationally. And so I think as researchers, it's fundamentally important to really take that variation and yes, I understand it means it's messy and that can be a challenge as researchers. But when I think about the home and community-based services settings rule, for example, and the changes that are occurring there to really set standards to ensure that all people receiving home and community-based services have access to the full benefits of community living, we are going to need continuous ongoing research to see how that actually occurs and what that looks like across the country.
I want to turn to another topic, and then there are some really great combination of comments and questions that have come in from the audience, and I want to share a few of those and get some reaction. But I do think it would be worth a moment. Javier, you mentioned earlier your the work you did at the state level on COVID-19, and you know, it is sort of a commonplace now for people to say that COVID-19 lay bare the inequities in our health system, and it certainly is a true statement. But then the question is, what do we do about that? And much of the public discourse about the response to COVID has been about the disparities on a racial and ethnic basis of who was most affected. But there are also, as you know, well-documented disparities with respect to disability. And I wonder if you could just share a little bit about how the folks you worked with approach this and what you think can be done to get us to a better place.
Sure. Well, I think we were very fortunate in New Jersey to have gotten a group of people together who probably would have never even talked to each other had COVID not happened, because, you know, they were parents of people with intellectual and developmental disabilities. They were individuals who have, you know, family members in developmental centers, right? Where we talk about the Olmstead ruling and making sure that people are, you know, not institutionalized. And we had a really strong group core of people from different backgrounds. And I think when we came together, we sort of weren't sure if we can actually do anything about what was happening on the ground to people with disabilities, what the horrors that all of us saw on television on a nightly basis. And I think what made it work for us was the fact that we decided to put those longstanding issues aside for a second and say, you know, I'm a person with a disability just like you. And, you know, you may be a parent of someone with a disability, but at the end of the day, we're all going through this together. And if we could find some commonality, some things that unite us, we can probably move forward. And that's exactly what we did. You know, we didn't get hung up on, well, you support institutions and you don't. We didn't get hung up on, well, you know, this disability or that disability. We just said we all have a common cause. And we actually were able to get legislation in the state of New Jersey addressing some of these issues, everything from emergency management, you know, services to a bunch of other things. But, you know, we also said that it's important to empower people with disabilities. And I don't think we do that enough. I think especially in the community, you know, individuals with disabilities are struggling by themselves. But if we could think about the power of these 67 million people, you know, who would come together and say, education is important. Education is a right. Access is important. Home and community-based services are important. And really push those issues as issues that affect us all, like, you know, Dr. Izoni and Dr. Long said, I think we would move the needle forward a little bit. And now I think we have the ammunition, which we did not have, you know, pre-COVID. We've seen how many people with intellectual and developmental disabilities died in these congregate settings. And that goes back to what Dr. Forber-Pratt said, that these are systemic issues, long-standing systemic issues that are not going away anytime soon. So we do need you, Ellen, and the policy individuals such as Dr. Besser and other people to really look at what we can do to get out of this so we're not in the same situation.
Lisa, yes.
Yeah, and thank you, Javier, for such a kind of powerful example. Let me just say, though, that here's where intersectoral issues really arise. So think about people who need home and community-based services. A lot of them need personal care assistants to come into their homes. Personal care assistants are typically low-wage workers, often women of color, often immigrants. And sometimes they're young and have their own kids at home that they had to stay at home and not do their job because they had to homeschool their kids during COVID. And we're having trouble now getting enough PCAs in Massachusetts because people could get a lot better paying jobs if they just go down to the local supermarket now, which is, you know, or the MBTA, you know, they could get a much higher paying job if they, you know, just look a little bit now under the current market conditions. This has to do with immigration policy, labor policy, minimum wage policy. And so here's what I'm saying, that it's really intersectoral. It really is not just health policy. Here is where we need kind of an all of government approach to this. And it's going to get to be a bigger issue going forward with the aging of the population.
Well, I want to take a moment to just read. These are on fairly different topics, but I want to read them together, and you all can respond to one or others of them. And the good news is many of these topics will come up in later panels, so it's not as if we have to answer all of these right now. But one person asked about what steps have been taken or can be taken to increase awareness of disability among physicians and medical students. And we, of course, will talk some about the care delivery system later, but the importance of having positive stories around disability in medical education, so that disability isn't just about ADA and accommodations and lawsuits. I thought that was an interesting way to put it. Dr. Forber-Pratt, someone specifically thanked you for talking about the importance of identifying as part of a disability community. This person says, I don't want to tell someone else how they should identify, but when I reference someone with a chronic illness, it's important to view that as part of the community of people with disability. There was a question about someone from a university who's an educator trying to prepare their students to be inclusive, asking for advice for educators for being more inclusive. Someone just sent in a question about increasing pay for personal care assistants. I know we have a paper on that. I'll just also note, when I was in Colorado, there was something called the Colorado Cross Disability Coalition, which I kind of assumed there was one of those in every state, but I looked around and it isn't that common. And so the siloing of different communities within the disability community, I think, is a real barrier. On the one hand, you want to commune with people who share the concerns and interests and needs that you have. On the other hand, I think we do lose something by separating out. So I know I covered a number of different topics, but I wonder if any of you, as we have just a few minutes left, want to weigh in on any of those around education or bringing subgroups of the community together.
Well, Dr. Iazzoni and I have been comrades in arms on medical education for many years now. We both play a role in medical education at UMass Medical School, where I'm based. And I also work on a project at Tufts Medical School to provide medical education on disability to our students. And what would be most helpful in moving those efforts forward would be requirements that disability be included, and also that having disability included on the board exams that medical students have to take in order to move forward in their careers. That, I think, would help to move disability further up on the priority list and really further our efforts.
I was just
Yes.
briefly going to say that, one of the ways that I get my students to be involved is that I don't give them a choice, right? Because professors can give a choice or not give a choice. So, my students have to be involved with a disability-related agency sometime during their semester, either through volunteer or through writing a paper, where they have to go and work with individuals. So I think that's an important thing. I mean, people with disabilities have never really been given a choice to some of the things that we have to deal with. So I think it's important for the future individuals, at least in our department, who are going to be PTs or OTs or doctors, to really understand disability from that firsthand setting. So that's one of the ways that I do it.
And I would add to that it doesn't, and this is something that I commonly say to groups of residents or new medical students or grand rounds presentations, that it doesn't matter what subspecialty you're going into, you're going to encounter people with disabilities. And then I often share at that point the list of the 12 different specialists who are currently on my own medical team. It doesn't mean that because I'm not going into physiatry, which is spinal cord and rehabilitation subspecialty, it doesn't mean that you're not going to encounter somebody like myself and others with disabilities. And so really helping to change that mindset of, oh, yes, I might be a, general practitioner who encounters people with disabilities. I might be a gynecologist who encounters people with disabilities and so forth.
Well, these are great comments to lead into our next panel. So I'm going to say thank you to Drs. Iazzoni and Long, Drs. Robles and Forber-Pratt. Thank you for kicking us off with such rich discussion and a variety of topics, many of which, thankfully, we will have a little more time to explore over the course of the afternoon. With that, I'm going to hand the leadership over to Javier Robles, who will be the moderator for the next session, which, as I mentioned, will be focusing really on issues of care delivery. We've got some terrific papers. Javier, I'll turn it over to you.
Great. Thank you, Ellen. So I'm very happy to be here today hosting this distinguished panel highlighting multiple dimensions of care delivery affecting people with disabilities. I will briefly introduce all the panelists at the top, and they will each then pass the microphone to the next panelist. For more information about these talented contributors, you can find their full bios of the group on the event page at healthaffairs.org. So we will begin. So Susan A. Chapman is a professor in the Department of Social and Behavioral Sciences at the University of California, San Francisco School of Nursing. Tara Lagu is the director of the Institute of Public Health and Medicine in the Center for Health Services and Outcomes Research and professor of medicine and medical social science at Northwestern University School of Medicine. Rocco Freebell is the director of the Global Surgery Policy Unit at the London School of Economics and Political Science. Lisa M. Meeks is director of Docs with Disabilities Initiative and assistant professor in the Department of Learning Health Sciences and Family Medicine at the University of Michigan Center for Disability Health and Wellness. Ilham Abor-Bershoev, I'm sorry if I messed up your name, is a research scientist at the Lurie Institute for Disability Policy at Brandeis University's Heller School for Social Policy and Management. And now I turn it over to Susan Chapman to start us off.
Thank you so much, Javier. Can you all hear me?
Yes.
Okay, can we move to the next slide? And the next slide, please. So I'm going to talk about, and thank you, Lisa, for that great introduction to my topic. I'm going to talk about how finding a personal care aide in rural America may be difficult, but in general, how finding a personal care aide in America might be difficult. We have three main themes in this paper that we addressed in the data and in our analysis. We came at this issue from a workforce perspective, which is the background of much of my research and in the background of this paper. Some of the questions are who might potentially need help with care in their homes if they identify as having a self-care disability. Many surveys have found that people prefer to be cared for at home and to age in place at home. Personal care aides are the paid workforce most likely to provide those services. It's in their description to provide, help with self-care. But are there enough of those folks? And we know that there are chronic workforce shortages in this workforce for reasons that have been mentioned a little bit, and I'll go into a little bit more. And I'm going to use the shorthand PCAs in the rest of this talk, so personal care aides. Are PCAs available in areas where they are needed? We decided to look at the geographic distribution and with a focus on rural needs. For the data for this study, we used the American Community Survey. It has a question on self-care disability. Do you have difficulty dressing or bathing? That is the only question we used from that survey, because again, we felt that this is the workforce most likely to be able to assist with those difficulties. We used the American Community Survey question about work and place of work to identify PCAs and where they were working. And we used the Office of Budget and Management definitions of metro and rural areas. After analyzing these data, we created maps to visualize our findings. So on the next slide, we have a map. Hopefully you can see it clearly. This map shows the percent with self-identified self-care disability from the American Community Survey. The ranges are from 1.2 to 2.6%. What you see are the lighter shades in the country, to 3.9 to 8%, 8.7%, which are the darker shades. And this kind of tells you where they are, what the distribution is in the country. Looking at this map, we see higher rates of disability scattered across the US, but more concentrated in the South Central and Southeastern states. The next map, we looked at where's the supply of PCAs. This shows the supply of a ratio of PCAs per 1,000 adults who identified with this self-care disability. The low number is between 0 to 95 PCAs, and the highest number is from 324 to 683. These are precise numbers, but you see kind of the general findings there. So putting the two maps together, you can say we have fewer PCA workers in geographic areas that most need them. Some additional analyses, but not found in this paper, we broke this down into rural areas, the metropolitan areas, micropolitan areas, which include rural areas, and then non-core areas, which are the most rural areas. There's a graph in the paper basically showing that PCA shortages are most intense in the rural areas. And looking at this map, we can see parts of the country that are most likely to have a shortage of PCAs where there's the potential need for self-care. Again, we are measuring potential, not actual, because we don't have the data to say actual. And that takes me to my next slide. What are we going to do about this? In terms of data, we could use some better models of what should be the right ratio of workers to population need. How do we know what the right number is? We don't really have good studies that show, what is needed in terms of ratio, or where people are available, or how this varies in parts of the country and in even parts of states. As we talked about, states are so variable in their coverage of this work and benefits. Where do we need people the most? Has already been said about PCA jobs. They are low-paid jobs, often without benefits. Many PCAs live in poverty. Many more live in poverty compared to other sectors of the workforce. It's undervalued work. None of this is new information. We have known this over time in many studies from many different perspectives, but we haven't made much progress. So how are we going to address this? There are in terms of rural challenges, there are particular challenges working in rural areas. Those include transportation, travel time between clients, reliance on a vehicle. There's no public transportation. Transportation would involve also getting a client to a health appointment or for shopping or other activities. It's very isolating work, and often internet connectivity is poor. So looking at kind of technology and solutions sometimes don't always work in rural areas. We need fundamental changes to our model of funding as we look at how we continue to shift to care in the home. How to pay sustainable wages, how to make these jobs better, recruit new workers, new types of workers, older workers, younger workers. What do we need to provide for incentives? Looking at family caregivers, the policies are inconsistent state to state. So how do we recruit, train, retain, and make these decent jobs? Big picture questions that have been on the table a long time. And then thinking about rural areas, we need rural specific solutions for people who need self-care living in rural areas, and also for rural workers in these areas. And of course, we need to listen to the voices of rural residents and workers when we address these solutions. So I thank you very much. The next slide is just my name and my contact information. I look forward to hearing your questions. Thank you. And I will pass this on to, let's see, Tara.
I'm here. All right, we'll move to the next slide. Thank you so much. I'd like to thank Health Affairs for inviting me. This is an incredible opportunity, and would really like to thank my co-authors and the senior author on this paper, Dr. Iazoni, you heard at the beginning of this presentation, and she's been an inspiration to many younger researchers. And I just want to thank her personally for all that she's done to mentor others and further this field. Additionally, this work was funded by the NIH, and the grant number is listed here. Dr. Iazoni is the PI. Next slide. So as we've stated already, more than 61 million Americans have a disability. Next slide. And as Lisa stated so eloquently in her introduction, there are more than 50 years of laws that have attempted to provide care and access to care for people with disabilities, from the Rehabilitation Act to the ADA, to the ADA Amendments Act, to Section 1557 of the Affordable Care Act. And yet, persistent disparities exist in access, quality, and outcomes for people with disabilities. In an effort to better understand why these disparities exist, we sought to do focus groups to talk to physicians and understand their perspectives on caring for people with disabilities. Next slide. So from a database of more than 800,000 physicians licensed nationwide, we identified 22 physicians to participate in 3 anonymous focus groups. These were about 50% men, 50% women, representing diverse subspecialties and geographic locations. And again, these were anonymous. They were conducted on a video conferencing platform, and we only knew the first names of participants. Next slide. During these 3 focus groups, we asked physicians about their experiences and barriers that they've experienced while caring for people with mobility, hearing, vision, mental health, and intellectual disabilities. Next slide. We identified a series of themes, which really were themes that emerged as barriers that physicians experienced to providing care for people with disabilities. These are, I'm going to list them, but I'm going to go through them in more detail. So don't worry, they're physical barriers, communication barriers, barriers in knowledge, experience, and skills, structural and system barriers, ADA knowledge, and attitudes. And on the next slide, you'll see that within this attitude slide, sorry about the box there, some physicians describe specific strategies that they used to discharge people with disabilities from their practices. Next slide. So I'm going to go through the various themes and barriers that physicians describe, starting with physical barriers. So when physicians talked about physical barriers, they talked about problems with access to buildings, a lack of accessible equipment, lack of knowledge about how to use accessible equipment, and that includes tables and weight scales, and an inability to transfer patients with mobility disability from a wheelchair to an exam table. As one physician said, our medical assistants just write wheelchair and the weights don't get checked until someone makes a big deal about it. Additionally, some physicians reported that when patients who use wheelchairs need to be weighed, they send the patients to other places, including grain elevators, supermarkets, and zoos. Next slide. Physicians also described communication barriers, that is the inability to accommodate people with hearing, speaking, or visual disabilities. And this includes a lack of access to sign language interpreters or high cost of sign language interpreters, a lack of access to printed materials in Braille or large print, and difficulty speaking with patients who have hearing problems, including this quote: "Most of my patients have hearing aids that are just not working. It's better to use paper and pen." Next slide. When talking about knowledge, experience, and skill barriers, physicians described a lack of training in how to care for people with disability, a lack of trained staff in how to use equipment, a lack of understanding about how accessible equipment works, and a lack of knowledge of disability etiquette. Said one physician, "I don't even know how to care for people with disabilities. I'm not qualified." Next slide. Structures and systems was actually a very big kind of group of things, and that included procedures with getting patients in and out of clinic settings. So for example, is there something in your scheduling system that tells you the patient's coming? Is there a field in your EHR so that you know what accommodation needs those patients have? Are you able to book a room and get them into a room with an accessible table? Additionally, there was also sort of a lot of themes about, are you adequately reimbursed for your time, or are you allotted enough time to provide the care that patients need? As one physician said, seeing patients at 15-minute clip is absolutely ridiculous. To see a patient with disability in those timeframes is unreasonable and unacceptable. Next slide. Physicians reported almost no knowledge of the ADA and in some cases expressed negative attitudes towards the ADA. I truthfully think the ADA makes the disabled person more of a target and doesn't help them but hurts them, because a lot of us, me personally, are afraid to treat them. We just don't want to deal with them. Next slide. We had a lot of content within our attitudes barriers, but I want to focus on one specific area of the attitudes section, which is that in two different focus groups, several physicians spoke about strategies that they use to discharge people with disabilities from their practice. This includes saying that they don't take new patients, they don't take the patient's insurance, the patient doesn't need the care that they want, or in this case, I've thought about it a lot because in a sense, we're kind of powerless, in a powerless position to deny care. My solution is to say, I no longer take new patients. Next slide. I say, I think you need a lot more care, and I'm not the doctor for you. So in summary, I've talked about a lot of barriers that physicians have described in caring for people with disabilities. In my summary, I'm really just going to focus on this last piece about physicians who spoke about denying care to patients. And I'll summarize some of that on the next slide. So physicians make discretionary choices all the time about what insurance they take or what patients they see. But the laws are very clear. Physicians do not have the right to discriminate against people with disabilities. What's tricky, though, is that some of these excuses were potentially discriminatory, but we don't actually know if the physicians took the insurance or, they were taking new patients or not. And so identifying intent is difficult. So you can imagine how difficult it is to enforce the ADA. Next slide. Additionally, some physicians were overwhelmed, just demonstrating the problems with our healthcare system. But nevertheless, our findings suggest that physician attitudes and bias play a role in perpetuating disability disparities. And I'm going to leave you on my last slide with the last sort of sentence of our paper. Perpetuation of inequitable care for people with disabilities is inconsistent with the mission of medicine and public health. And I'm going to pass it on now to Dr. Rocco Ferbel.
Yeah, thank you so much, Tara. And thank you so much for the kind invitation to be here today. And great kudos to the entire team of Health Affairs for making this special issue happen. And I think, as was mentioned in the previous panel, I think it provides the ammunition needed to inform decision makers to shift policy. And I think there's just so much valuable information in this entire special issue. So I'm very pleased to be part of this. I'm just going to present one of the works that comes from the United Kingdom, specifically England. So a little bit of an international perspective. And even though it's focusing on the NHS, I think the lessons that are or can be derived from this research, can be universally applied to the US system and other healthcare systems. And specifically, this work focuses on the hospital safety of patients with developmental disability. It was, developed in partnership with Laia Mainu, who's my co-author at the University of Barcelona. So if you can please go to the next slide. So the idea of looking at patient safety is really not new. The policy focus, and there has been a huge policy focus over the past 20 odd years, really spearheaded by the publication of To Err is Human in 1999 by the then Institute of Medicine in the United States, which identified that or stated that up to about 98,000 patients die while being hospitalized in the United States. And since then, quite a lot of research has been published in this space. Some figures, some articles are putting patient safety at about 1 in 20 patients who experience a preventable physical injury while hospitalized. And recently, there has been a report published on Medicare patients, which suggests that up to 25% of all Medicare patients experience physical bodily harm while hospitalized. And these are things such as adverse drug reactions, pressure ulcers, hospital-acquired infections, really all things that aren't supposed to happen while you seek care and while you're the most vulnerable. And if you put that into an international context, the OECD, for example, estimated that about 15% of all hospital activity and all expenditure in health systems is simply to correct for patient safety failures that are happening in hospital. So there's a huge burden for healthcare systems, a huge burden on patients. And I think more research really is needed to understand what are the patient groups that suffer most from patient safety events. And that is one of the gaps that our research tried to address. If you can please go to the next slide. So this work was motivated by some previous work we have done looking at high need patient groups. And those are individuals with relatively high complexity, elderly patients, patients who are suffering from multiple diseases. And we found that those patient groups, those that have the highest care needs, tend to experience the highest patient safety incidents. We then shifted the focus into patients with developmental disabilities. And as was rightly pointed out here by the previous speakers, also in the previous panel, there is some evidence out there that suggests that patients with developmental disabilities experience poorer quality hospital care processes. They're less likely to receive chemotherapy on time and other processes, and they ultimately experience poorer outcomes. There's some other studies that indicate that patients receive the wrong medication, or they receive medication that is not really based on any diagnosis when admitted to hospital. And then again, a study that looked at pediatric patients, just to give a flavor of what is out there. But the bottom line is there's no systematic approach to assessing what type of care, what quality care patients with developmental disabilities receive when they access care in hospitals, when they are admitted to hospitals. And this is what we try to address with our research. Next slide, please. So our analysis was based on patient-level data, routinely collected claims data for the English NHS. And just to remind you, the English NHS is a tax-funded healthcare system that does not discriminate, is free at the point of access. So essentially, it provides universal health coverage to anyone and everyone who needs it in England. And we looked at patients admitted between 2017 and 2019. We used diagnosis codes to classify patients into 4 different disability categories. And we looked at 5 different patient safety indicators that are widely accredited and acknowledged in the wider literature. But by just simply showing you these summary statistics, I think I just wanted to highlight 2 main points. If you look at the age, the mean age of individuals that are admitted to a hospital in England, you can see that patients with developmental disabilities are between 10 and 20 years younger than those patients that do not have developmental disabilities. And that itself showcases that something is going wrong in the community. There are some reason, for some reason, the community services, the network of primary care physicians, the care that is being provided to those patients in the community does not seem to be adequate in England. And equally, if we look at the number of emergency admissions to hospital, we can see that a much higher proportion of individuals with developmental disabilities arrives at the hospital unplanned compared to patients with no developmental disability. Next slide, please. We then looked at 5 different patient safety indicators. We looked at adverse drug reactions, hospital-acquired infections, pressure ulcers, post-operative pulmonary embolism, deep vein thrombosis, and post-operative sepsis. And even though this picture is relatively heterogeneous, I think you can see that especially individuals with chromosomal abnormalities, so patients with Down syndrome, are much more likely to experience hospital-acquired infections, pressure ulcers, sepsis. So something is really, some aspects of care that is being provided to those types of patients does not meet the same standard as the care that is being provided to patients that do not have any developmental disability. Next slide, please. But instead of just looking at the crude rates of patient safety incidents across different patient subgroups, we then matched patients based on their characteristics. In other words, we try to compare individuals that have a developmental disability and a certain disease profile and age demographic profile with patients that do not have a developmental disability. And we try to estimate what is the additional risk that those patients face with regards to one of those 5 patient safety incidents. And what we found is, again, that throughout the entire disability groups, developmental disability groups, and the different indicators, you can see that patients with developmental disabilities have significantly higher risks of experiencing one of those patient safety incidents. And for some patients, this risk is about 3 times that of patients without developmental disability. Next slide, please. We then went a little bit further in this paper and we assessed what implication that has for length of stay as a measure of health system efficiency and also mortality. And we can see that, or we estimate that for patients that experience a patient safety event while being hospitalized, average length of stay increases by up to 15 days. And we also see a significant increased risk in mortality.
Great.
So what are the policy implications? And I will stop right after this slide. I think there are some key lessons for the community level, specifically around access, caring for patients in the community, making sure they don't need hospital care in the first place. And then, of course, at the hospital level, we need to include carers much more frequently, much more systematically in the care processes, because carers are best placed to pick up when something goes wrong. We have to educate those that provide the care, and similar to what the policy push in the United Kingdom right now, we have to try and shorten the period that patients are exposed to the inpatient care.
Great, thank you.
So much.
I think Dr. Meeks, you're next.
Thank you so much. Hello, and thank you. I want to take a moment to recognize my colleagues who are listed on this slide, and also the researchers, many of whom are here today, that have come before us. And truly, without all of their foundational work, our work would not be possible. I also want to make a quick note before I begin that I'm going to use both person first and identity first language and switch between as a way of recognizing and respecting the variation and preferred language among people with disabilities. So thank you very much. Next slide. All right. In our collective work, our teams noticed an alarming downward trend in the disclosure of disability from UME to GME and then into the practicing physician pathway. And as this slide outlines the various data sources or publications, it's important to note that I was on all of these research teams, and I can attest to the use of the same questions across all 3 populations. And so we are actually looking, while the data didn't come in one group, we are actually looking at responses to the same questions across different stakeholder groups. And of course, thanks to the work that's been done, even today by Dr. Iazoni, we know that physicians harbor bias and stereotyped beliefs, ableist beliefs about people with disabilities. And overall, we know that mistreatment of physicians is a pretty large issue in medicine, which can lead to burnout and to attrition. This often comes from the patient population versus the peer population. And so given that there was no data on the mistreatment of physicians with disabilities and noticing the downward trend, we decided to do this study. Next slide, please. And what we found was really sobering. We found that 64% of physicians with disabilities experience some form of mistreatment, putting them at higher risk of mistreatment than the general physician population. Next slide. And this mistreatment occurred across the board, literally on every single measure of mistreatment. And surprisingly, it occurred from both patients and peers, which was a new finding. The magnitude of our findings were also really surprising. And people with disabilities had a significantly higher likelihood, 2 to 17 times more likely of experiencing mistreatment. If we could go to the next slide. So this full model is in our online appendices to the article. Okay, next slide. For trainees and physicians with disabilities, the pathway to successful training and working often requires the use of accommodations, and this necessitates disability disclosure. However, we know that there's a fear of bias, stereotype, stigma, and workplace mistreatment that may result in lower disclosure rates. In fact, we think our rates on previous studies are probably low. Non-disclosure can also lead to internalized stress, cognitive preoccupation, hypervigilance among trainees. The fear of bringing one's authentic self to the workplace can really create internal stressors and necessitate workarounds in order to avoid asking for accommodation. This results in additional fatigue, physical, mental distress, and feelings of isolation. So you can see how these things work together. Next slide. So our findings really highlight the need for immediate and systems level intervention and training that's also focused on the value of disabled physicians and the need to create a safe, equitable, and supportive workplace. So what can institutions do? Well, first, they can collect data. You've heard this theme across many of our presenters today. Monitoring the recruitment and retention of individuals in the workplace is going to require data collection. This can also help us identify where attrition is happening in that pathway. They need to conduct disability training to make sure that people are aware of the value and the benefits of having disabled physicians in the workplace. Increase efforts for inclusion, and create and promote reporting. So reporting systems for mistreatment must be shared broadly and incorporated into trainee and employee onboarding. This should also allow individuals to report encounters where disability is the root cause of mistreatment, and that is not present in many of the mistreatment items today. Policies must provide clear expectations for employees and for patients specific to multiple types of harassment, including overt and covert behaviors. And leaders, and this is incredibly important, must codify clear consequences for those who do not comply with non-harassment policies. Unfortunately, we don't think that these policies will be enough intervention without a culture of trust and accountability. Unfortunately, there are multiple barriers to reporting, including the belief that nothing will be done, not knowing the process for reporting, and mostly fearing reprisal for reporting or loss of employment. Therefore, it's really important that institutions recognize the necessity of creating working and learning climates, cultures, and policies that support individuals with disabilities and that encourage reporting of mistreatment. Institutions must then follow that reporting by taking action and providing protection to these individuals against retaliation. The highest ranking leaders of healthcare should endorse these trainings and policy implementations by stating their own commitment to this and communicating a zero tolerance approach to disability discrimination and mistreatment. Thank you so much.
Dr. Akobirshoev, right? I think you're next.
Yes. Okay, for my slide.
Can
Thank
we
you very
bring-
much, Health Affairs, for your kind invitation to present findings from our study where we examined delayed medical care and unmet care needs due to the COVID-19 pandemic among adults with disabilities in the United States. Before I start, I'd like to acknowledge my co-authors, Michael Vedder, our own Lisa Aizoni, Soumya Rao, and Monica Mitra. Next slide. Everybody knows the devastating impact of the COVID-19 that had on people with disability in the institutions during 2020. Let us recall the mass media breaking news about the widespread COVID-19 infections and deaths in nursing homes, initially in Washington State, then in Harlem neighborhood of New York City, then in New Jersey, and many, many other institutions where people with disability live. It is believed that during this time, 2020, almost half of COVID-19 deaths are attributed to the institutions. Again, I just want to highlight that almost 100% people who live in nursing homes are people with disabilities. Studies also found that the risk of death during this time period from COVID-19 was 3 times higher among people with disabilities compared to non-disabled counterparts. And the risk was even higher among people with disabilities from minority community, and 6 times higher among people with intellectual and developmental disabilities. So we know quite a bit about the impact of COVID-19 on people with disabilities in the institutions, but there was really little information about the impact of COVID-19 on people with disabilities who are not institutionalized, who live in their homes, in communities, on their own or with their loved ones. Please, next slide. So we decided to fill this gap by conducting the study that looked at the unmet needs for medical care and delayed medical care because of COVID-19 pandemic. We used 2020 National Health Interview Survey. Between July and December, the survey included COVID-19 model and 17,635 non-institutionalized adults answered those questions, including 1,851 people with disabilities, with different types of disabilities, including vision, hearing, physical, cognitive, and self-care independent living disabilities. So our main study outcomes included, because of the COVID-19 pandemic, medical care was delayed, needed medical care for something other than COVID-19 was not received, and needed care at home from a health profession was not received. So let's see what happened. Next slide. This slide shows the unadjusted prevalence ratio by presence and type of disability. And I'd like to draw your attention to the left side of the slide. The first 3 columns, they represent our study outcomes. So the first column in green is prevalence ratio for delayed medical care. The second column in orange is not getting needed medical care for something other than COVID. And the third column in blue is not getting needed care at home from a health professional. So in ideal world with perfect equity, these columns shouldn't be above the red line here or the orange line here, which represents people with no disability as a reference group, and with prevalence ratio equals to 1. Alas, and unfortunately, as you can see, these columns go beyond that line, significantly higher, and which represent the disparities in delayed medical care, not getting medical care for something other than COVID, and not getting care at home from a health professional due to COVID-19. And more specifically, people who had any disability, they were 44% likely not to have to delay medical care, 78% likely not to get needed medical care for something other than COVID, and the striking 7 times more likely not getting care at home from a health professional. Now, think about people with disabilities where there are significant demand for healthcare and services that they need if they were not in the institutions. Next slide. This slide shows the adjusted prevalence ratio, again showing the keeping everything equal and adjusting for sociodemographic characteristics, and also highlighted here the access to virtual medical appointments. And again, even with this access, you can still see that this disparity persisted, and they were all statistically significant, and across all even disability types. Next slide. So in terms of policy implication, we were thinking, to list a whole set of policy actions that could make all the disparity go away. But we just wanted to reiterate what the National Council on Disability recommends for a long time and thought these will be the most important policy action that could start moving the needle to make away these disparities. And first, to designate people, as Lisa Izoni and Long Believe mentioned, to designate people with disability as a special medically underserved population or health disparate population, because that comes with certain benefits. For example, National Institute of Health will establish centers for excellence for research, education, and training. Hopefully, research from these centers will identify barriers and the root causes of structural inequities affecting people with disabilities. And as a disability research, of course, improve data collection concerning healthcare for people with disabilities, and specifically by incorporating standardized disability and types of disability identifiers in all public health surveillance systems, electronic health records, Medicaid claims data. So we as a researchers, policymakers could see in real time what's going on with people with disabilities. Thank you very much for your attention and looking forward to our discussion.
Great, thank you. Thank you for all the wonderful presenters we've had. So I just want to remind everyone that if you have a question, please put it in the chat and we will try to get to it. I know we have limited time. I would like to start with one question for whomever wants to answer it. If you can make one policy change today to most radically address systemic inequities in care delivery for the disabled, what would it be? And I know that's a big ask, but just one thing to really address what we've heard here today so far.
I can go first.
Sure.
Basically, that was the number one policy implication I mentioned, to designate people with disability as a special medically underserved population. Again, this is a legal designation, and it comes with a number of benefits. And we know from precedents with other disparities, based on race, ethnicity, gender, that really start, bringing in specific policy action items. Like, as I said, there should be centers for excellence established. Then, of course, the most important, then disability will be considered as a demographic. You would collect information same as you would collect information on race, ethnicity, gender. So that will be very helpful, because otherwise, as they say, if you can't measure it, it doesn't exist. Thank you.
True.
I would second that by saying I think the data problem is one of the key reasons why we lack the same kind of policy changes that we've seen to address issues, which are clearly not addressed, but issues around racial disparities in access to care and other things. If we can identify the population, we can better identify the problem. Without that, we face real challenges in figuring out where the problems are and how to address them.
Great, thank you. Anyone else?
I think I said in my presentation this, but I'll repeat it, and that's in workforce policy, looking at the workforce that cares for people in their homes. What I gave you were very conservative estimates, looking at only one sector of the workforce that might provide care, and also one type of disability. If we're going to age in place and people need care at home, we really need to address the workforce issues and this mishmash of policies and LTSS and home and community-based services, what people are paid, what's paid for, et cetera.
Great. I have an audience question. How will shift to digital care affect care for people with disabilities? Anybody can take that. Dr. Legume?
I mean, I think it addresses some of the access problems in terms of transportation and other kind of real world concerns. But frankly, have you had a digital appointment? They're not that satisfying. And I don't think it's the answer it's not a panacea, that's for sure. I think we need, I'm a physician, and I like to see my patients in person and examine them and touch them and connect with them. And I'm not certain that digital solutions are going to answer all of that.
I'd like to second what Tara said, and actually, our study provides empirical evidence that access to digital, the virtual medical appointment doesn't explain the disparity. It doesn't make them go away. And in fact, if you read our papers, people with disability actually had higher rates of access to virtual medical appointment, and yet you saw the disparities. They are significantly much higher. So.
Yeah, absolutely.
And just to add to that, the rural piece, digital access is very inconsistent across the country, particularly in rural areas.
Another question. In the presentation on bias towards disabled physicians, it was acknowledged that there may be attrition in the pathways for disabled people to become physicians. This is also true in academia. To that end, I'm curious about whether these efforts had disabled academics as co-authors, and if not, how the disability community was included in design of the research in this panel. So I don't know if Alan wants to take a stab at that or someone else.
I can speak
Okay.
to my paper and in particular, our team's paper, because I think it's a really important question. And so I applaud the person asking it. And I think it's something that we don't talk about enough. So our lab, my lab, is absolutely informed and grounded with researchers, not just MDs, but PhDs, people with master's degrees, masters in public health. And at least one person on every paper is a person with a disability. But I would say that our team of about 10 people, out of the 10 people, about 9 individuals identify as having disability. And this is across multiple categories. We do this work and our work is informed by people with disabilities. The other thing that I think is really unique to this work that you're seeing and our team's work in particular is that we always include a learner. So we are not as proximal, right, to what's happening in the trenches for a medical student, a resident, or a physician. And so we will include representatives from those populations, all of which are individuals with disability in this work. It's one of the things I'm most proud of our team, but it also has the byproduct of then mentoring, sponsoring, fostering the next population of individuals that are focused on disability research. So we are in and of our work itself is kind of creating a pathway for people with disabilities in medicine to go on, because what we're not talking about here in this current paper is what happens to people once they become employed and go into that academic kind of hamster wheel of assistant to associate to full professor and all of the barriers therein in academia, which I think your participant is asking about.
Thank you. And I'm just gonna assume you're the exception and not the rule, as we've heard from a lot of people here today. So
I think a lot of research teams are including individuals with disabilities and have individuals with disabilities on them. I think there's disparate access to opportunity for those teams to engage in the work.
Okay.
I would just add that our team also has people with disabilities, but beyond that, I would say just to comment on the problems that are pervasive throughout academia and the medical community. We don't have a intact education system for teaching within medical school or residency. How do we teach medical students and residents about disability? Because part of that and part of changing the culture is how we're going to get more people with disability to come into the field. So it's really about being inclusive in a variety of ways, not just about on specific studies, but really in everything that we do in education. It's got to be our culture and our community are part of it. And I think that's where we really need to work as a profession.
Thank you. And a shout out to Rutgers Medical School, who I'm actually presenting on next week, who do a great job at bringing people with disabilities in to talk to future doctors. And they have a great program set up. So Alan, thank you.
Thank you, Javier, so much for the panel. And thank you to our panelists. A great conversation. There's a lot more content for the rest of the day. We are about to take a short break, but I do want to say that as during the break, we are going to feature a short slideshow of the work of artists from a program, organization called Art Enables, which is a Washington, D.C. based professional art gallery and vocational arts program that supports artists living with disabilities. Art Enables is dedicated to creating opportunities for artists with disabilities to make, market, and earn income from their original and compelling artwork. Artists are largely self-taught and tell powerful stories through their artwork. One of the pieces, Pies Going All Around by Eileen Schofield, is featured on the cover of the October issue. We'll be featuring the artwork throughout the month on our website and our email newsletters, social media, and the like. A number of pieces will be on display at the event this Thursday evening in the community, as well as will be hung permanently in our offices in Washington, D.C. So we're going to take up just 5 minutes. We'll be back at, let's call it 2:52 Eastern. And just take a quick breather, and we'll return to the program in just a few minutes. Thank you all.